Well, good afternoon, everybody. I think we'll get underway just 1 minute past 4. So my name is Paul Anderson. I'm the Managing Director of Orthocell, with the developers of a cellular therapeutic called autologous tenocyte implantation. We're the proud sponsors tonight of tonight's webinar into the developments in the biological treatment of tendons. I'm delighted today and this evening to have with us 3 outstanding presenters, Professor Ming Zheng from the University of Western Australia, Dr. Jeff Hughes, a specialist upper limb surgeon in Sydney, and Associate Professor Jane Fitzpatrick, a sports and exercise physician from Melbourne. So without further ado, we'll move into the program. As we know in clinical practice, the treatment for tendinopathy can be challenging clinically. What treatments do we use at what time point? And what treatments are we using to address the underlying pathologies to treat these problematic patients? We know now that there's a much better understanding of the pathology of tendon, and particularly the pathology at different stages in what we describe as the treatment algorithm. And we know that it goes from an inflammatory acute phase through into a more chronic degenerate phase. And what we've been able to do is to really attach to those phases a pathology or a histological examination of the tissue that represents those phases. And that provides us with a treatment algorithm that enables us to make clinical judgments and decisions about what we intervene with and when we intervene at those different time points. That's a lovely segue now into Professor Ming Zheng's presentation. Professor Zheng is a full professor from the University of Western Australia. He studied his degree in Shantou University and Sun Yat-sen University in China before moving out to Australia, where he holds a full professorship at the University of Western Australia. Professor Zheng is really focused in regenerative medicine in the areas of bone, tendon and nerve repair, is a pathologist by specialist training, has over 200 peer-reviewed publications and is regarded as an expert in the development of basic science in the area of regenerative medicine, specifically for musculoskeletal issues. So without further ado, I'll hand over to Professor Zheng, who's going to provide us with some insight to the cell and tissue engineering of tendon and a new era of treatment-resistant degenerative tendinopathies. And I hand it over to you, Professor Zheng.
Thank you, Paul. Good evening, everyone. Tonight, I'd just like to share with you some of the up-to-date information on tissue engineering of tendon and the tendon cells for treatment of tendinopathies. As we all know, that there's over 600 tendons in the body, and tendon is really passive mechanical sensitive tissues. 80% of the mechanical loading down to tendon are really what we call uniaxial loading, and the small portion of the mechanical loading with what we call the tensile strength as well as the compression strength. Our recent landmark publication in Science Translational Medicine this last month have stated that tendon really is a metric that can store the loading of the energy, and it is the tendon cells that converting the mechanical signal into the chemical signal for metric productions. And the tendon cells itself only can receive what we call a physiological loading called sweet spot of loadings. Too much or too little is not good for the tendon tissue, and in such what we call overload or underload of the tendon, we cause tendinopathies. Majority of tendinopathy often are self-limited conditions at the early stage, either receive treatment or no treatment, it will resolve by itself. But there are challenges ahead. With 10% of those patients, we have persistent symptoms and fail to respond to the routine treatment, including major physiotherapies. If patient with tendinopathy over symptom of 6 months, generally those patients we proceed into surgical interventions. This tendinopathy is not a life-threatening disease, but it's a condition related to disability and has a significant socio-economic impact. There are a number of theories linked to the pathogenesis of tendinopathies. The first series introduced by Barres in 1978 was simply saying that excessive mechanical stimulation will induce the tendon degenerations, just material property change. Later, people thinking about maybe related to inflammation, but there's a lot of this hypothesis has been disputed. But what we can see so far is that there are some evidence that in the case of tendinopathy, there's a presence of inflammatory mediators. The most popular series of tendinopathy is being the apoptosis series. The high doses of cycle strength, like repetitive load, with the oxidative stress, will induce tendon cells undergo programmed cell death, called apoptosis. A lot of other study has shown that tendons have also seen a vascular ingrowth or also neurogenic factor involved. But in those cases, we see that in fact, in the early stage, we can see a lot of increased vascular ingrowth to the tendon, which thus can also cause the weakening of the tendon and undergo rupture, what we call the angiofibroblastic hypoplasis. There are many of these series, but when we look at put it all together, actually, when you see at the early stage, often it's a reactive tendinopathy. That's what I see. 90% of the patient would probably resolve by itself. And then when progress into the second stage of tendon disrepair, which is a fail for the healing, then probably half of those patients will respond to some of the treatments of no-invasive treatments. And eventually, when undergo degenerative change called degenerative tendinopathy, this is an irreversible phase, which is what we can see up here, that in particular, on the center of the tear, you see a lot of cells undergo apoptosis and cell death and matrix degradation, degenerative collagen matrix, and leave a massive hole inside the tendons. But the surrounding of those holes, you can see, you still can see the early reactive change, which is what we describe as angiofibroblastic hypoplasis. So this is at the end stage, is a degenerative change with cells on the centers undergo cell death. This is an example of the pathology that we published over 10 years ago. You can see in the early phase, there's a reactive change, a lot of angiofibroblastic hypoplasia, characterized by a lot of blood vessel ingrowth and high density of these tendon cells. And in there, you can see all this reactive change at the early stage. You can see there's a low rate of the cells undergo apoptosis as compared to the degenerating phase. But on the same time, the cell density in the reactive change is relatively high, but as you proceed into the degenerative phase of stage 3, you can see there's a decreased cell number and increased apoptosis of the cells. And end up this is no functional tendon cells exist in the side of the tears. So years ago, we hypothesized that when reduction in tendon cells further reduce the collagen production and matrix degradation and what we call as a fatigue healing. So as a result, we propose that tendon cells injection to the center side of the tear and the outside guided, we probably improve the healing of the tendinopathies. With this, we start a lot of animal study as a preclinical study. I just run through quickly with some of the example here. We first labeling the tendon cells with nanoparticle, inject these tendon cells back into the rabbit Achilles tendon models. And we're tracking those labeling cells, seeing that in 12 weeks, we can see the labeling cells are well integrated into the tendon tissue, showing that injected cells are able to induce tendon tissue structure to normals. We're also showing that if we inject these autologous tendon cells into Achilles tendons, it not just restore the tissue structure, it also reduce the inflammatory cells infiltration. So it's able to reduce the inflammation as well as restore the tissue structures. Here's again the example that showing the tendon cells able to induce the collagen production and thus improve the mechanical strength of this tendon tissue that near to the normal tissues. With all this study, we move into the human study by first characterizing the tendon progenitor cells coming from the biopsy of the tendon tissue to ensure that the cells that we're growing are actually tendon progenitor cells that express CD44 markers and the CD90 markers. Not only this, we also look at the tendon marker production, including the collagen production as well as some other metric productions as well. We're further down to ask the question, is these tendon cells also produce growth factors? And as you can see, a panel here that tendon cells can produce predominantly platelet-derived growth factor A and fibroblast growth factor B, as well as transforming growth factor betas. All these factors are essential for the tendon regenerations. The next step we've done is to take these tendon cells, putting in the bioreactors and mimic the in vivo condition by giving a passive mechanical loadings in the bioreactors. In that, we saw that if we're giving these cells for mechanical loading or up to 6% of their length, then we can see that the loading can induce tendon tissue formation and all the tendinogenic marker. At the same time, they also reduce the chondrogenic and osteogenic differentiations. The in vitro forming tendon tissue, what we call as a neuron tendon tissue, are very much resembling to the new embryonic tendon tissue. Like this is a mouse patella tendon tissues from the embryo. You can see the morphology is very similar to the human tendon tissue that you put in the bioreactors, so the 6% of the loading. And again, you can see that tendon cells itself forming the tendon tissue in the ex vivo systems by produce type 1 collagen as well as tendon modulins, and very similar to the in vivo tendon tissues. So a quick summary here, we show that the tendons need tendon cells to respond to mechanical loading for the anabolic actions. Animal model has shown that injected tendon cells can be integrated into the tendon structures if they survive. And these injection tendon cells not only just restore the tendon structure, but also can reduce inflammations. Human tendon cells from the tendon biopsy, if they undergo uniaxial loading in the bioreactor, can also form in the tendon tissue. And those tendon cells can produce growth factors necessary for tendon formation. With all this information, we package these to formulate a first clinical study back to 10 years ago. So we start by doing a tiny needle biopsy from the patellas, obtaining this tiny little tissue, grow the tendon cells in the GMP facilities, and we inject the cells back to the patient. But before the injection, we have to go through all the regulatory requirements, typically by what TGA requires. We have to identify and ensure that the cells inject back to the patient, they are patient's own cells, and the purity, potency, identity has been demonstrated. It's tendon cells, and they produce tendon markers as well as all growth factors. Most importantly, they are, before the injection, they're viable, and it goes through the aseptic process that contain aseptic process that is safe to put it into the patient. So we're using this, what Oxford University recommend the ideal framework to stepwise introduce of this tendon cells injection technology, from the idea to the development and to the exploration. And at the moment, we are at the stage of assessment. So this is some of the example that what we have done in the past. The first study was a pilot study that we have of using autologous tendon cell injection for the treatment of lateral epicondylitis. And subsequently, we have about up to 4.5 years follow-up of those cohort of patients. Furthermore, we also use this to treat gluteal tendinopathies. Here is an example of some of the clinical study on lateral epicondylitis. Very much the patient after receive autologous tendon cell injection, you can see the dramatic reduction of the pain through the quick dash score. And I think this account for the fact that what we're seeing, the animal study on this phase, we're able to see the inhibition or the reduction of the inflammation response by the autologous tendon cells. And subsequently, from the 1 year to the 5 year, up to 5 years outcome, we can see continued improvement. And this is a reflection of the structural improvement of the tendon tissues. So likewise, all the score has a great improvement, and in particular, the grip strength is have also got continued improvement from 1 year to 5 years. So generally speaking, if the injection, patient after receive the injection of ATI, if there's an improvement start from 3 months, then most likely there's a continued improvement up to 5 years from the study that we observed. We are doing a lot of RCT study, but this is some of the study that we're putting all our data with the literature together for the comparison of the treatment of lateral epicondylitis. As you can see that from surgery, this is the red line is a surgery up here. The blue line is the corticosteroid injections, and the green line is the ATI injection. And we got the longest follow-up from in the literature on these procedures, and from the comparison with the literatures, the death score itself are far more better than other surgical and non-surgical intervention. But this is just the comparison with the literatures we due to conduct the RCT study. Currently we use this ATI to treat a lot of arthritis patients. This is some of the example, and you can see from the publications. One of the pivotal study that we are doing at the moment is the comparison of this ATI technology with surgery in patients with chronic resistant lateral epicondylitis. It's almost halfway. Because it's a blinded study, we haven't yet to know the final outcome, but it's soon where we have the data. With this, I just conclude that ATI provide both functional and structural repair of the tendons in patients with severe tendinopathy, and most of those patients are failed to respond to conservative treatment. A high level of clinical evidence is completing. Thank you very much.